So the treatment landscape of metastatic disease, and clearly most people agree that everybody should get like some sort of taxane, trastuzumab, pertuzumab as first line. As second line right now is trastuzumab emtansine or TDM1. And then in the third line, we have a lot of options. And I think it depends on if you have disease in your brain or not. If you have disease in your brain, then it definitely is a HER2 TKI. And we have tucatinib, trastuzumab, and capecitabine, which I think is a standard of care now from the HER2 CLIMB data. We have neratinib and capecitabine, where if the other triplet's not available, there's lots of areas of the world where it isn't, where neratinib is available. And neratinib, if you give it as a dose escalation, you start at maybe 160 milligrams a day and gradually escalate with a lot of antidiarrheals, you can overcome a lot of the diarrhea, reduce the incidence of grade 3 diarrhea down to under 10% if you do that. But, the issue is that, so you have those for above the neck disease. For both predominantly below the neck disease, I think trastuzumab deruxtecan with that phase 2 data from a year ago and the update that we just had now at San Antonio really is dramatic. I mean, we're waiting for the phase 3 trials, the Destiny, I think it's 02, to actually report. And when it reports, given the PFS in the phase 2 is 19 months, with an overall survival of 2 years and heavily pretreated disease, I think it's a big deal. And so that's kind of where the landscape looks now. I think that stuff that's coming out, we have other antibody drug conjugates. We have something called SYD985, which is slightly different HER2 HER2 antibody drug conjugate with a slightly different payload. We have margetuximab, which actually kind of recruits the immune system, supposedly, by having more antibody drug dependent cytotoxicity because of some changes in the FC receptor that have been engineered into the antibody, the margetuximab antibody. We also, have a lot of immune approaches that people are thinking about, bispecific antibodies that bind to HER2 as well as to HER3 or HER3 and PD-1. I mean, there's all sorts of combos that are being kind of developed. This whole concept of like trying to overcome a suppressive immune system on top of giving anti-HER2 therapy, I think is a trend that we're going to start seeing more and more of as the years go on. It's an exciting time. There's a lot of interesting stuff.